Hey everyone.
Hello, hello.
Howdy.
Hello. John, I'm trying to figure out what's around your clock.
Uh, little magnets,
Oh.
and a Dolly quote which says, "Have no fear of perfection. You'll never reach it."
I like that. And
That's
and the
good.
philosopher Dolly is amazing to quote, by the way.
Yeah.
A great philosopher. And how are you doing, Liz? You're at a conference, or you're going to a conference, right?
Yes, APA, American Psychological Association conference is this weekend. So I apologize, you guys, but my flight's in 2 hours, so I wanted to be on the stream. So I drove to the airport, sitting in the airport parking garage to do the stream so then I can still make my flight. So sorry for the car background, but here I am.
You know what's crazy? Like the way it's done, I wouldn't have known it was a car.
Oh, the
Right. She
window.
fuzzed it out. Yeah, but you
Yeah,
but you blurred it out.
I
So in
know.
the
But,
blur, actually, it's the seat behind you. It looks more like you're already on the airplane.
oh, let's pretend that's where I am. Chris,
Yeah.
how are you? Give us updates.
I'm good. I'm good. Yeah, I don't have any complaints. Yeah, I was really excited. I just did 4 podcasts, and it was really cool because besides talking about OCD, I got to talk about body dysmorphic disorder, also the correlation between body dysmorphic disorder and eating disorders, and then the hosts are both like about to go into college. So we were just talking a lot about like how it's shifted the conversations around mental health in their generation as Gen Z, me as a millennial. And it's just great to see. I mean, they have clubs at schools now, like mental health clubs. Kids are encouraging each other to find evidence-based treatment. They're having conversations with each other like, hey, I think this is more than your friends can help with. You've got to talk to the counselor. You have to get therapy. And those conversations were not happening when I was that age. So I just think it's such a testament to the work that we all do in this room, the three of us, as well as just other organizations that are trying to get the messaging out there. So it just made me have a little pep in my step that the that age is a little bit more open about mental health and getting treatment earlier.
They really are. It's awesome.
Yeah. How are you doing with 17 kids?
I'm here. They're all doing that was so funny. They're doing good. They're busy, keeping me busy, but everything is good. John, give me. I want to hear everyone's thoughts on conference. Do they feel excited, rejuvenated, ready to hop in? What is some of the buzz? What's the latest language y'all were hearing about?
Are you talking about the conference, the OC conference that just happened a month ago?
Yes.
Oh, there's buzz. No, I think it was a really nice conference. It worked out pretty well. Nothing. I think. Well, it's always the same in a positive way. So I
Good.
think once again it was the same in a positive way. Or everyone's lying to me.
One or the
I'll
other.
never know.
We
Yeah.
ought to start today's live stream with a great comment for you, Chris. John. Amy said, welcome to our special guest, the Freedom from OCD guy, John Grayson. Your book was the foundation for her freedom from OCD, and lots of adding onto it occurred. So that's awesome.
So I'm humbled, and I'm glad I could be helpful to her.
Yeah, Amy's a great friend of the show. What because it's in a new iteration, right? A new uh what do you call it? Not iteration, but
No,
Version.
I mean,
version.
the version that's out, the 24 updated,
Yeah,
is
that's what
what
I
they
meant.
call it. They did ask me to update it again, but I didn't have enough to add. I didn't really have enough to change it from the last update in 2014. I would have loved to have had an excuse, but so instead, Liz and I are working on a book.
We are.
We are.
Whoa.
We're working on a book on social on coping with uncertainty for everyone, not just for OCD. You know, now I did think that Liz would be really organized and crack the whip so that I couldn't procrastinate. Turns out she's no better than me, so we're dragging each other along. So we're not keeping to a tight time schedule, but we're still in the process of moving forward. And um,
But I have
have
17 kids, so I have an excuse.
that's right. And you're pregnant with 14 more.
Yes. I know Liz knows I'm the whip cracker when we do talks together. I'm like, I'm sending the slides, we're getting it done. But I don't have kids. That's my excuse. If you, I'm
To
going to put it out there.
To my defense, I'm very good at like executive functioning around like my emails are always perfect. My task, if someone gives me a strict deadline, I get it done. But like John and I are not good at deadlines and like holding each other accountable. And so we're both like, oh yeah, we'll try to get that done by Sunday, and it doesn't work. But I set a goal for the Sunday, and I might have sent it to at like 11:53 p.m.
No, you did. And I'm going to make our goal today.
Okay.
It probably would work better if I was in Houston.
True.
If we had to see each other all the time.
Oh, for sure.
Well, I'll just throw it out there. I'll do my little pitch. I have now written 2 forwards to books. I just wrote the forward to Scott Granite's brand new BDD workbook for teens, as well as the contamination workbook. So I'm like the bridesmaid. I've never written a book, but I always write the forward. So if you need somebody to write a forward of a book, apparently that's my strong suit, because I'm the only one on the planet that hasn't written a book. So
you may be able to tell our progress by how long it takes for you to get that request.
Exactly.
Well, ask Scott. I got my forward in weeks in advance, so I can do that. Just don't. I'm the bad at emails. That's the thing I'm bad at. So, we're glad to have you on, John. Dr. Grayson, John.
I mean, I can call you Mr. Trondsen if you want, but if you like Chris, I'm John.
My young clients call me Mr. Chris. It's so cute. Anyways, welcome everybody to the live stream. Obviously, we are here with a really good friend to the program, John Grayson, Liz McIngvale, myself. We're excited to answer your questions, discuss some topics. We know we had a lot of pre-submitted questions. We have live questions. The only reminder is this live stream can't replace any kind of crisis counseling or intervention. So please, 988 lifeline.org or dial 988 or 911 local emergency room. Talk to a clinician. Like, please get the help that you need. We're here to give resources, education, and support. As always, there are, whatever platform you're on, YouTube, Twitch, Facebook, etc., there is a place to write comments and questions. Please support everybody in the chat. People love hearing from other people going through this horrific disorder. But you can also ask questions for John, for us, and we'll chit chat. Well, what I want to start off with is, you both talked about like accepting uncertainty for everyone. Why is that important? Why is that such a key kind of component to wellness and just life for anyone, but our community specifically?
You know, particularly in these times, I mean, everything is uncertain. And, you know, I think there's a different, you know, I believe at the core of OCD, people are trying to attain 100% certainty, you know. So it doesn't matter if something's low probability. People want absolute certainty. Now, I would find it hard to imagine anything certain. I can't think of anything that's absolutely certain. You know, there's even one scientist who says that the odds are that we are living in a simulation. You know, there's some people saying, obviously, that's like not a real thing. We're not living in a simulation. That's not possible. There's a physicist who says, given the way statistics are, you know, there probably are simulations. And because there probably are simulations, there are probably more simulations than the real thing. We are probably a simulation. What's the probability? You know, so, you know, and I think that practices that say we can teach you to be certain because you can trust yourself, well, you know, I think that's like saying, well, you just know it's OCD. You know, if somebody would say we can teach you to be comfortable with low probability, we can argue about how we would get to teaching you to be comfortable with low probability, but I mean, in some sense, that is the goal. You know, everything is kind of a, you know, is it worth doing this for this low probability or not? You know, this is so unlikely. But low probability is not the same as no probability. Should I worry about airplane parts falling out of the sky, or is that just like obvious it's not going to happen? Except when my son was 10 years old, there was this local school, public school, where an airplane crashed into a helicopter over a schoolyard during recess and children did die. Now, really low probability. I don't think it's worth worrying about the airplanes falling out of the sky, but it's not zero. Or I don't know when I say my favorite one. I had a client who was concerned that maybe she could kill people with her thoughts. You probably both have heard this. And you know, most people were going to her like, you can't do that. And some would say to her, that's not a real thing. You know, we can teach you to understand that's not real. I, of course, when she came to treatment, said, well, maybe you can kill people with your thoughts, but you have a low hit rate, because to date she hadn't killed anyone. So I said, in treatment, we're going to have you work on killing people with your thoughts, not to prove it can happen, but because you're driving yourself crazy, spending 24/7 trying to make sure you're not having killing thoughts or undoing them. And I kind of set it up, during the course of treatment, maybe someone will die. You don't get to know if you do it or not. I think you should stay in treatment. Maybe you'll knock off a second person. Really unlucky, low probability, I want you to stay in treatment. You can knock off 3 people, 3 separate occasions. A busload counts as 1. 3 separate occasions. Okay. Let's try to control your thoughts and call the CIA because they'll probably have use for you. First week of treatment, we worked on killing her father. At the end of the week, he died.
Like he really died?
Oh, no, he really died. And he wasn't sick. He wasn't like anybody, it wasn't like he was on his deathbed or anything. So, did she kill her father with her thoughts?
No.
I don't know. I mean, where would I bet money? I would bet not, but I can't prove it. And if I had been in some kind of treatment saying, that's stupid, that's not going to happen, I'm in trouble. I used to have fun with cognitive therapists who would, use exposure as proof and then say like, so what would you do with this case? Which always kind of got them stuck. So she stayed in treatment and got better and no one else died. So did she do it? Did I do it? Did it not really happen? Was it a coincidence? But the thing is, I can't prove anything for sure. I can give odds. And, I feel like, so I don't conceive of a world where I know anything for sure. And again, it's one thing to say that probably won't happen. I'm not going to argue. But no, it won't happen at all. Well, the answer is still probably. I think everything is odd. So treatment is saying you can know something for sure, trust your senses. Well, gosh, I mean, trust your senses. If we look at our political situation, we have 2 diametrically opposed views of the current administration. Okay, one side is wrong and both sides are sure they're right. What is trusting your senses in that case? Or people with different religions. They're very sure of their religion, but with multiple religions, somebody's wrong. So I can have really strong beliefs. I have strong beliefs, but if you ask me, do I know they're correct? It's like, no, I'm okay not knowing for sure.
Yeah, while you're speaking, John, I mean, one thought that I had is there is never enough information, right? And although we want to learn how to trust ourselves, et cetera, right? It's really difficult to do with OCD. And I was thinking while you're speaking, I remember the neighbors' houses were being tent for termites. And I mean, I reached out to the CDC when I was that desperate because my OCD was so bad. And they sent me stuff from the FDA. I spoke, because they have the name and number on the tent. I called them. They're like, dude, like we have to pass it. I mean, I knew more about tenting houses probably than anybody else outside of people that did that for a living. And it still wasn't enough. And I think those of us with OCD, the more effort we put in, with your client trying to figure out if her thought we're hurting people don't realize we're validating the thought and we're actually making it feel, not actuality, but feel more likely to happen. And then that just has a spin even more. So for me, the only way I finally got past that was saying, hey, I have to trust that, they're going to seal the tent the best they can. I can't control it. People tent houses. I will go through my life. And if I end up getting cancer or something, I will sue the crap out of everybody. And that's my only kind of solace. Yeah. But I had to finally let go because the more research I did, there was never like enough. The goal
because the EPA, what if the EPA standards are, lying?
Exactly.
And I mean, you brought up something interesting about any kind of ritual. All our behavior we do everything because we're either reinforced for it or it happens next to it. Like reinforce, and this is fun to do to people. Whenever we're talking to people, periodically we pause, and every time I pause, you nod your head. So the next time I pause, you may decide to not nod your head, but even if you choose not to nod your head, you're going to feel uncomfortable because you've been reinforced, without even knowing You kind of know if I don't nod my head, I'm going to get like, what? Hey, are you not listening? So we do that automatically. And we also respond to anything that is paired together. You know, we see food, we get hungry. It's 12 o'clock, we get hungry. So rituals are actually paired with another thing that we've learned. Rituals, because of the way OCD is, are paired with doing more rituals. So as soon as you do a ritual, you're actually increasing the urge where you're getting, because you're always in fear of, I don't want to get into that hell where I'm doing it over and over and I'm like, ah. So it's kind of like the act of doing a ritual actually increases urge, makes it you feel more like doing a ritual, which is why so many people get caught, why you always lie when it's just one. And so it's like basically, even though you're trying to fix it, you're really in a hole and your way out is trying to dig deeper. That's the scientific reason for what you just described. It's actually, it's actually true. The ritual make you want to ritualize more.
Yeah, I think that brings up a good question that Janice asked at 12:05. She says, would love your thoughts on the OCD brain and addiction. My son has managed to get himself stuck in a place where the compulsions are not giving him the reward they used to. So the compulsions are going on for hours, causing great distress. It actually feels more like an addiction at this point than OCD. And you were kind of just speaking to that.
Well, you know what? The underlying learning theory that describes how addictions work and describe how compulsions work is very much the same. I mean, both people with an addiction and people with OCD is like, I'm just going to do it one time, or, oh, I'm so upset right now, I can't really deal with this, so I'm just going to do this. It's like, well, if you just do this, you're going to have two problems, not one. That doesn't work at that time. So all those things are very much the same. I think the prime difference is that addictions tend to be appetitive, meaning they're kind of fun. Like you may not want to be an alcoholic, but you do like getting drunk. Whereas nobody's like, wow, I just wish I could wash my hands for 5 hours. That would be so much, like, that would be great. So OCD behavior is generally avoidant in some way, right? I'm either trying to fix something, avoid something, or get around it. So it's more anxiety driven than I'm looking for that. But so there is that underlying similarity, but they're driven by different things. So in some sense, what makes addiction so hard is that, like, they are fun to do. I don't really want to give it up.
Yeah, when Dan Spiegel, he's a neurologist that's written some books. He came and spoke at my grad program, and he talked about the brain similarities of addiction and OCD. And he said people with OCD, when they do their compulsions, they release a lot of dopamine, just like an addict. There's lower levels of serotonin communication, and so there isn't that part of the brain that's saying, "Hey, enough, buddy, like back off." But what he was saying, similar to compulsions, is just like somebody who uses, right? Somebody that uses a substance, they get to a point of tolerance. And that's what we all feel, Janice, the same as your son, is there's times where we just do compulsions to survive at that point. We've been doing them for so many years and so consumed your life that you're not even getting the relief anymore. Now you're just doing it to be able to move through the day and function. And that's why I always tell people you want to get treatment earlier before it becomes to that point. Because it sounds like her son is just needing that just to survive.
Yeah, and I just want to hop in for a quick second and remind everybody, as John is saying, is that addiction at some point or has some sort of component that we would call egosyntonic, right? So it feels good. It kind of, it's something that brings pleasure, joy. OCD compulsions do not. And yes, you're right. It looks addicting because the more we do them, the more we need them, right? I always talk about this with patients with OCD, but majority of patients have been at the place many, many times where they'll say, I wish I wouldn't have started doing this ritual because I feel worse now after doing rituals than I did before I even started doing them. And that is such just like yeah, you're right. Well, why? Well, because when I start doing a ritual, I'm sending the message to my brain that I should be able to get certainty. And what we know is that certainty is not possible. It's actually not something that you can achieve. And so the more you keep doing behaviors to try to achieve it, the more stuck and confused you become, versus if you can from the beginning just accept that uncertainty, that actually for most people is easier than trying to get that perfect feeling through rituals that's almost impossible to get. And then to go back to what John was saying earlier about providers who say, OCD treatment's going to give you certainty and or I can give you certainty by rebuilding these things. Here's what I always tell people. During OCD treatment, we have to tolerate uncertainty. However, I want to make sure everybody knows that the goal is not that for the rest of your life, the way you would have to accept uncertainty is how you have to accept it now. Right now, having to do that in treatment is really triggering, really anxiety provoking, really hard work. It's really difficult. Once you've actually done the work, if you've done ERP appropriately, you can get freedom from these thoughts so that, yes, you're still going to be accepting uncertainty, but you won't even be recognizing that you're accepting uncertainty, right? You're going to accept uncertainty the way you do for all the other things in your life that your OCD is not attached to. Right? People with OCD actually still accept uncertainty every day of their life around things that they're not worried about. If you're not worried about driving, you get in the car and drive every day. There's a ton of uncertainty around that, right? If you're not worried about being late to a meeting, you still accept meetings, and there's a ton of uncertainty about whether you're going to be able to be there on time or not, right? But what your OCD is attached to, it makes you think you can't accept that at all. And we want to teach you that you can. And so what I always like to tell people is that after OCD treatment, you will trust yourself again, and you will actually have good clarity. I can't guarantee certainty, but I can actually get you to a place of clarity where you're able to be very clear after treatment. They're like, oh, that's my OCD, right? That's my desire to want certainty. And I can let that go and not be triggered by that anymore.
And be uncertain. It's not like, oh, that's what it's saying. That's not, because some people like, that's my OCD is a way of trying to get certainty, which I know you don't mean. It's kind of like, all right, I can accept that one, because, when people are going for certainty, they always think of it as a logical thing that certainly has logic to it. But really what they're going for is a feeling, because you just pointed out as you were speaking, nobody gets in a car and knows they're not going to have a car crash.
Right.
But they're comfortable with that low probability. Whereas the OC thing, I'm not comfortable with the probability. Same thing. So I can't get somebody to, so even though everybody will agree, yeah, I get in the car, I don't know if I'm going to die today, I just hope I don't. But they are comfortable with that, and they're calling that some kind of certainty, even though they're not. Or, your loved ones, if not with you in the room right now, you don't know if they're dead. They're probably alive, but you don't know for certain. But I can't get you to be upset about it. I can't make you feel uncertain about things that you're comfortable with, and I can't get you to feel the opposite, the other way around, before I confuse myself.
Right. But I think that's the exact point, is that we want you to be at a place where you're able to tolerate the uncertainty that everybody tolerates every day of their life. And the caveat to that is that most people, because you're tolerating it, you don't even know you're tolerating it, right? Because why? Well, it's not triggering you. You don't know risks you're taking if you're not focused on the risks, right? But the risks don't change. The fact that we can't completely eliminate or give you we can't eliminate uncertainty. We can't give you 100% certainty, but I can make you feel pretty certain or confident or have
probable.
clarity around
probable.
Something. Or probable is John's favorite word, whatever word resonates for you. But again, it is a feeling, right? I can make you feel good about that, or feel okay about that, or feel like you're willing to take the risk, or that it's not triggering to you, but I can't eliminate every single potential risk, right? But I can eliminate you being afraid of it.
Yeah. And we have the feeling of certainty because in our daily life, without realizing it, we're constantly reinforced with the belief of certainty. That is, there are all these expectations we have that we aren't aware of. I expect when I go out of my office door, I'm not going to be confronted by a bunch of terrorists. And every day I'm not. I expect when I turn on the water faucet, water's going to come out. I expect the lights to come on. I don't expect my wife to be dead. I have all these expectations without realizing it. And most of the time, my expectations are met, giving me that level of predictability gives me this comfortable feeling of certainty. But it's an illusion because low probability events happen. So the goal is I need to learn to be happy in the world where disaster can happen. And the only thing I can do is say, if it happens, my goal is to try to cope with it. Some people say it's like, I couldn't cope with that. That's kind of denial because you're in a fantasy world in a sense like, oh, really? You have a choice? Like, where are you going to make sure that never happens? Like the beginning of the COVID things, like this can't last all summer. Now people kind of laugh at that now, but at the time when they were saying that, it's like they were almost pretending without realizing, well, there's some other place you can go where that's not true. And if you know where that place is, like I'm willing to come if you know how to actually get there. You'll have to convince me. That seems a really low probability, but hey, you can do that. I'm there.
Well, I think also people hear the words like acceptance and tolerance and think that that's like, an action or they like it. I think that's the thing that I always hear clients say to me is they're like, wait, you want me to have acceptance, but I don't like these thoughts. I don't like these feelings. And I always have to educate people. Acceptance to me is just a passive approach versus an active approach. When people come in, they're taking a too active approach. They're trying to find certainty. They're trying to get reassurance. They're trying to move their world around to avoid triggers. Acceptance is simply an acknowledgement of what is and saying, okay, I'm going to take a passive approach. And although it may, if I'm driving home tonight and my brain is telling me I'm going to hit someone, an acceptance approach is not like, yay, I love hitting people. It's more so I'm going to do my best and something may or may not happen. And like you said, John, I'll have to land on my feet, figure out how to cope and work through it. That's all we can do as people.
You are missing the core secret about acceptance. Acceptance sucks.
Oh, yeah.
Because acceptance means I'm going to choose to try to cope with the second best life. If I lose a spouse, like, and the thing about, I talk about death, the really important thing about death is nobody gets to decide to go right to acceptance. We all start wishing, I wish she were still alive, and if I'm going to successfully mourn after a year, I could still miss my wife. I could still cry about it, but I'm no longer to be comparing every moment to, I wish she were still here. I had this family where they lost 2 kids. I won't go through the whole story, but I said something like that in the first session. They want to know, like, how is this going to work? And I said, I think it'll be just words. And they agreed. And I said, well, after a year, you'll stop wishing that. And the dad wrote a book about grieving. And he wrote that when the therapist told me, that about not wishing them alive, he thought, F him, I'm never going to stop wishing my kids are alive. But then he wrote, now 2 years later, I've come to realize it doesn't do me or them any good wishing they're still alive. So he's not wishing that anymore. He still misses them, but that's different. So acceptance is, I'm going to try to make the best out of the second best life. And there are many reasons to do that. And the main reason is you don't have a choice. Yeah. Because the first best life doesn't exist. And some people don't like the idea, like, I don't want to live in a world where me or my family could die at any time. Take me to your world if you can find it.
Well, and I think the part about acceptance sucks is really important, because I do think that, listen, if any of us could create a treatment that worked for OCD that didn't include it being really hard and sucking, we'd be happy to do that, right? But the reality is that that's not how it works. The treatment that truly gets you free from OCD is going to mean you have to face your fears. You have to face anxiety. You have to approach the things you've been avoiding. And so guess what? Of course that's going to be hard. Of course that's going to be triggering. Of course it's going to be really disruptive, right? Dysregulating, all the things. And that is how those fears, those feelings, those triggers will no longer control your life. But if you want or try to go down a path of treatment that is like, we're going to do a soft approach of my fears and triggers, or I'm not going to have to actually do any exposures because that would be too hard or too triggering, you are not actually going to be able to approach your fears and get freedom from it. You might be able to do some things that would make your fears get a little quieter, or maybe put them a little bit more in the background, but that's not the goal of ERP. The goal of ERP is not, let's push fears down. Let's just like move through our world and not focus on our fears and see if we can still live a values-based life while we're really struggling. I hear people say that a lot. That's not our goal. Our goal is, let's actually slow down and face the fears so that you can live a values-based life, not controlled by your fears. And so I want to be really clear about that, ERP should not feel like this brutal treatment forever. Yet there are going to be times in ERP treatment, a lot of times, where you don't want to have to do that. You'd love to avoid that exposure. You'd love to not be triggered, because who wants to feel distress? Like, naturally, as humans, no one wants to feel discomfort. No one wants to feel anxiety. And feeling it, facing it, approaching it is how we move through it. That's how it no longer will have a grip on our life. And our goal is that if we truly approach these fears head on, they no longer will chase you. They no longer will be triggering to you. And the best explanation I ever had when I did a webinar with Shannon Shy, and I said, Shannon, where do you consider yourself now? And he said, I don't care if you call it cured, management, whatever you want to call it. I'm at a place in my life where I have no fear of any thought, trigger, in environment that OCD is going to throw at me and try to scare me with. And I thought that was such a great explanation of exactly what the goal of ERP is that we're not saying you're never going to be triggered again. We're not saying you're never going to have something happen that, you weren't expecting, but we're saying that you're not going to be afraid of that. And if it happens, you're going to know what to do and you're going to know how to move through it. And that is what ERP should do. It should get you freedom. It should be this treatment that really like unlocks the hold and grip that OCD has on your life. It should not be a treatment that just lessens the grip or that kind of just pushes it down. And if that's what treatment has been for you so far, I want you to sit back and really think about, am I doing ERP correctly? Am I not doing ERP? What's going on?
And just to add on to that and sneakily answer some of the questions while I'm answering it, in the words of Liz McIngvale, are you doing treatment to function or to get freedom? Because, think about ERP. What is your goal in ERP? If your goal is to learn to cope with uncertainty, to live in a world where the worst might happen, that'll work. If your goal is to somehow do ERP and not deal with uncertainty, it's going to interfere with treatment because you still have this underlying, this can happen. And of course, that's not real. I always say that people who overcome OCD are not normal. They're better than normal. The average person doesn't cope with uncertainty that well. I mean, better than an OCD suffer in the middle of their stuff. But so, it becomes really important that somebody learns to do that. And somebody wrote, is there a permanent cure? OC is learned in biological, so we're not changing underlying biology. Somebody may need to take meds always because meds really do something. But as we know, meds alone don't touch the learn part of OCD, so you're stuck with us. But can I reach a point where I'm able to cope with OCD in all its forms? And yes, and what many sufferers have pointed out, and we'll point out that if I'm trying to work with coping with uncertainty, it doesn't matter what form of OCD hits me. It's not like, oh, I was worried about hand washing. Now I'm suddenly worried about hitting people with my car. What do I do about this? They're all the same. And so when I have that underlying change, now the thing about that underlying change, we're not really just treating OCD, because if you're deciding I'm going to learn to live in a world of uncertainty, that is changing your entire life and how you approach everything. Because it's, and the thing is, though, that is true for all of us. It's, it's not like, oh, I don't have OCD, so I don't have to deal with uncertainty. That idea is foreign to me of like not living with uncertainty. It's, because I can't think, anything can happen at any time. And so I hope it doesn't, but that doesn't mean I won't have to cope. That's my goal. Hope to cope.
Hope to cope. So that's the next question I want to jump into, John, from Lewis at 11:10 my time. What would you say to people who aren't finding benefit in therapy or treatment? Are they having or doing treatment rightly? As I find lots of people asking this and not getting the right answers, it's leaving them feeling that having the super OCD that's untreatable, and it must feel really frustrating to them. And I want to just caveat this with Chris and I did a webinar on ERP with John Abramowitz a while ago, and we were talking about what ERP really is and what it should actually look like in practice, and kind of breaking all these misconceptions that are out there around ERP treatment and what it doesn't have to be and that sort of thing. And so anyway, one of the things I shared, and you've known me for a long time, John, is I said, I was a case where people would have said ERP didn't work for her, right? ERP like got me functional for 1 to 2 decades of my life, right? I had really good treatment, amazing clinicians, really good doses of ERP, really good ERP, both education and intervention from great specialists. Yet I was like functioning with pretty bad OCD. Like you saw me during that time, John. You know, I was in college. I was successful. I was from the outside, like doing stuff, but I was still really struggling, right? I was still holding on and doing OCD behaviors. And what I always tell people is that it wasn't ERP. It was my engagement with ERP, right? I was doing ERP with one foot in, one foot out. I was holding on. I was making choices and of how I was going to do ERP. Oh, I'll do ERP for this, but like I'm not going to do it for that, or I'm not going to do it all the way, or I'm not willing to address those things. And we all know what happens when you leave things on the table. And so I would love for you to talk a little bit about that, because oftentimes what I find is when people are saying ERP doesn't work for me, or it didn't work for me, or I'm treatment refractory, it's not that ERP didn't work. It's either maybe you weren't ready for ERP, or you were doing ERP one foot in, one foot out, or you were still holding on, or you were only using ERP to function. So like, of course, it feels like you're treatment refractory, because if you're just functioning like I was for 2 decades, I used ERP to like function, to literally be able to like get out of my house and make it to school. But I was still ritualizing all the time. And I was still doing ERP because I would like do exposures and not do rituals. And sometimes I was even not ritualizing, but I was white knuckling. I wasn't actually leaning in.
So I'm in agreement. I mean, we do a lot. I do a lot of supervision for the foundation, of therapists and therapists who are basically good therapists on board with everything we're saying. They'll bring me, a client. They'll talk about a client where they can't figure out what's going on, and like it's incredibly often where I'll ask them about the client and we'll talk about it, and it's like, oh, they haven't decided they want to learn to cope with uncertainty. They're still saying, oh yeah, that can happen. And, so the issue becomes they haven't agreed to treatment. I will not actually start ERP until I'm convinced that the client's willing to learn to cope with uncertainty. And sometimes somebody say, well, I don't know how to do that. And I'll point out, yeah, I'm supposed to be good for something, but so I think the real therapeutic skill initially is not being able to design an ERP program. I mean, most of the time that's pretty simple. The real thing is, have you convinced the person that this is the only path? That and the wonderful thing about people with OCD is they tend to be really logical. So it's really frustrating to talk to somebody who logically destroys the possibility of certainty. And it's like, okay, that's true. I don't like that. And I said, most people, I think, in treatment, when they're confronted with this idea, it really is only 1 or 2 sessions. But I've had people where it's taken 3 months to help them kind of decide, like, okay, I really don't have a choice but to, deal with this uncertainty. So the idea of what do I say to people who find that the treatment's not working? The number of people I have who actually fail and they're all in is pretty low.
Exactly.
I mean, it's really hard for me to find many. So it's not like I'm successful, but I have had some where it's like they don't want to do that. And of course, the other thing that's just makes all of this crazy, there's a lot of money in OCD treatment. So everybody claims they can treat it. And lots of people do a really crappy job. Some at least do ERP. They don't do it well, but even crappy ERP will be helpful. It's not going to cure you, but it'll be helpful. So as I get to the point Liz was describing of like functioning, even though you're suffering a lot, if that far. So, but the thing that's disappointing and to Lewis F is like finding good treatment is really hard. I mean, I thought, I've only done this for a little bit. I've only been working with OCD since 1978. And I kind of thought like, oh, in about 15 years, I might be like good for supervision, but I won't be anything special because everybody's going to be doing this because it works. We actually have data this works, and everything's for it. So it's kind of a shock to me that a treatment that the American Psychological Association, American Psychiatric Psychological Association both agree this is the first line treatment. IOCDF agrees this is the first line treatment. And we have data that works, and it turns out it's easier to treat OCD than to change the behavior of mental health professionals. It is so common. I was talking to a client who has a friend who has a friend who's a psychologist, just wrote a book about OCD, and their theory of OCD was like laughable, like it had nothing to do with anything they believe, and treatment had nothing to do with ERP. And it's like, and this person's written a book, so great. So yeah, it's really unfortunate that just because somebody says they treat OCD doesn't mean they do. And they may say they do ERP and they may not do. I mean, at least you can make sure they do ERP. If they're not doing that, you're really like, get the hell out. But after that, it's still like pretty rough. So I don't know what to say to somebody exactly, unless you're lucky and can find somebody. And of course, treatments also can be expensive. So that's a whole nother problem.
Well, I love what you said, John. I think I got a lot of crap defending ERP, from certain groups of people, because the core components of ERP, like you were saying, those are the core components of life. If somebody decides they want to open a business, there's a lot of uncertainty involved. Your business could fail. We know stat-wise, most small businesses fail in the first couple of years. People get a job offer to move to New York, and they're like, well, I don't know anybody in New York, but this would be a cool experience. There's a lot of uncertainty. There's a lot of doubt in life, and we have to make choices. And people that are more willing to like take risks and take choices are usually the people highly rewarded in life. The people that are going out and dating or meeting their partners, the people, who decide to have a family, if they want to have kids, are going to have kids. People that decide like, hey, I'm going to start my own business, or I'm going to travel, right? If people don't want any kind of uncertainty in their lives are going to be pretty small. And what we see in OCD over time for people, as they get worse and worse and worse, they're kind of homebound. They're stuck in their room because that's the one area they can control. And so when people are talking about this idea of ERP being, hurtful and torments people and stuff like that, it's like really good ERP doesn't do that at all. And what you said, John, is like the people that come in treatment that I work with, that you all work with, that really want to get better, I rarely see a client that's like gung-ho, comes to treatment and does not get better. That just does not happen.
And also this idea of we're torturing people. I tell people in the first session, I do not want you to do anything that I tell you to do unless I've convinced you. So I would way rather have you argue with me, and be convinced, as opposed to be a good little soldier and just do it, but you're not convinced. So if somebody's doing an exposure, I don't make anybody do an exposure. I might say a really nasty thing if they say, do I have to do this? And I always respond, only if you want to get better. Which people hate, because the logic of that's like, it's suddenly, oh, I'm not making you do this. This is your choice, and it's kind of like, the other pain in the neck, people say, I have to do this, and I always say, you have to? So yeah, I have to. So if I held a gun at you, you would still do it? Well, no. Okay. You can tell me it's a really hard choice, but it's important to acknowledge it's a choice.
Right.
Now, if you say, I feel like I have to, I can't argue. It's
right.
a great description of a feeling, but let's not fool ourselves with feeling versus reality.
Right. And I think what's really important to remember is that when people are like, do I have to do this? This is going to be so hard. This is going to be so brutal. Like, it's not any more brutal than the way you're living right now.
Oh, yeah.
In fact, it's much less brutal. Right. So what I want people to remember is that that's actually treatment. It's way more brutal. First of all, anticipatory anxiety is the worst. I was talking about this week in group, where someone was like, every time I'm approaching all these contaminated things, like every time I approach something new, it's a surge of anxiety. I'm like, yeah, so let's just approach all of it now. And let's just like move through it. It's already brutal. It's already anxiety provoking. Just address it all, versus like one at a time in this like slowly ripping that Band-Aid off, versus we just rip it off, and I don't know. I want people to be able to see and understand that when you actually dive in and let go, it's so much easier than when you're trying to make the decision each time.
Yeah. Salty Siren wrote, she's 29, lives with her parents who care for her, and she has been in the States since 13, has no idea what life would be like out, and it's terrifying. And it's true. It will be terrifying. but there are two really important. Well, I like to think of Fiddler on the Roof. Did you guys see Fiddler on the Roof?
No, I know it's a famous play, but I've never.
Okay. Did you see it, Liz? Oh my God. Anyway, a really weird thing about the film. If you ask people how did the movie end, I've only met one person who can tell me how the movie ends, which is shocking for all the people who've seen the movie. Because at the end of the movie, there's a people in 1910 in Russia in a Jewish ghetto. And at the end of the movie, the Russian government comes in and tells them, you have 24 hours to leave. So this is like the worst moment of their lives. This is like people, they've been living this way, for decades, and they have all these things, and they're going to have to leave in 24 hours. Now, the movie doesn't tell us, but historically we know where most of them are going to go. Do you know where most of them go?
They don't go.
No, yes, they do go.
Oh, they do? Okay, I don't know.
This is 1910, pre-World
Okay.
War I. Forget World War II and the Holocaust. So most of them will come to America. Now, the trip here sucks. These are poor people in a landlocked country. They're going on these giant boats. They're not in the good seats. And then they land here and like everything's like unknown. And so what I like to say is, look around you. You're in Russia. We're saying, come to America. It's unknown. It's scarier. But those people who left Russia, they missed the Russian Revolution. They missed Stalin and his Persians, and they missed Nazi incursions and the massacres to come here. So it would be scary to face the unknown. But as Liz said, even with the scary, there's at least potential opportunity versus your way is just hell. Because people sometimes say, it's so, again, it's not like do this hard work or go back to your nice life. If you've got a nice life with OCD, don't see me. That's crazy. You're coming because life is sucking and you're not, generally if you have OCD, besides trying to do something impossible, you're losing an incredible many things to it. You're not trying to, you're making your family miserable. And whatever the vision you have of the person you want to be, the person you could be, as long as you're not fighting OCD, you don't get to be that person. Why would you do this? It's like the only way there's a possibility.
Yeah, and what you've been doing hasn't been working anyway.
Exactly.
Yeah. Emilio, if you could put the comment that John's referencing at 12:45 from Salty Siren up real quick. One thing I want to highlight, Salty, from what Liz was saying earlier, what John just said, I think I was thinking while you were talking, Liz, the 2 years that I was in OCD treatment, although rough and challenging, was a vacation compared to the many years of living with undiagnosed, unknown OCD. But I hear what you're saying at the very end, Salty, and that's kind of been the theme of this live, is that the unknown is terrifying. Because the unknown is there, OCD fills in the gaps for you and tells you how terrible it's going to be, right? I think what happens, because I know a lot of people's family members will say to me, like, how does my son not want to try treatment? His current life is so bad. He's stuck in his room. He's doing compulsions until 5 a.m. It's because it's known. It's what you know. And so, Salty, that's what John was talking about earlier, that willingness. And that's why I did a lot of training in motivational interviewing. And when a client comes to me in this point, let's reflect. And you've talked about it, John. Let's look at what we've lost to the OCD. Let's look at what life is truly like. Because I always tell people, even if treatment's 2% better, let's do it. But it can't be worse than what you're doing right now. So I hope you hear this live stream and see the kind comments to you, Salty. Treatment is better.
And she says, I've heard of Hitler. Isn't the end terrible? Well, I mean, they're kicked out of the country, yes, but and that looks terrible, but they're no longer going to be pogroms where the Cossacks come in and like just kind of knock them about and hurt them and burn their stuff. And again, they're not going to, go through World War I. They're not going to go through Stalin and his Persians. They're not going to get massacred by Germans coming in World War II. They're going to come here, and although not everything may work out, it's kind of a lot better than happens if they had stayed. So sometimes what looks bad at the moment turned out to be a blessing. So yeah, they're sad to be leaving, but they're going on to some other place.
Yeah, and I think one thing I'll say, I just want to give a caveat, is that sometimes people will say, doing ERP does actually feel worse. And I think that is important for us to spend a few minutes on, is like, if that's how you're feeling, if you're doing ERP and it feels actually worse than what it was like before you got to treatment, and you're like, I'm not getting better and I'm doing this brutal process, we need you to hear us saying you are not doing ERP correctly. Maybe you don't have the right provider. Maybe the way you're going about it is not right. But if we're doing ERP while still holding on to safety behaviors, and we're actually doing ERP, which is like, to me, through while white knuckling, that actually at times can feel more brutal than just not doing ERP at all. So, and I think y'all have heard me talk about this. I do think a lot of advocates send the wrong message. I think on social media and a lot of places, there's this message that's being sent that like ERP means you just have to learn forever, that you can do hard things and you can live by your values while still really having to push through and do hard things and struggling. And I worry and I fear that the way individuals with OCD understand that and like accept that is, oh my gosh, I'm always going to struggle, and ERP is just to get me some functioning right now. And that does sometimes feel more brutal than not doing it at all. And so I want to be clear, ERP should be getting you freedom. You should not be having to spend the rest of your life struggling with anxiety and OCD every day and just pushing through. Like, if you're doing that, you're using ERP as like a what I would call a fear extinction tool, and to just address the current symptoms you're triggered with versus actually addressing your core fears and truly leaning in and truly letting go.
And if you think about coming to acceptance can be very painful. I mean, the fact it's pain, and so I sometimes think ERP might be as hard as having OCD. It's just that one is endless rituals and the other leads to an end of rituals. But, again, acceptance, there's a mourning process. If I lose a loved one, that process of coming to acceptance, of like accepting that death, that's a painful, awful process. And the alternative is to mourn the entire rest of your life and never having a life. So it is a big deal moving to a world where there's really uncertainty and I have to accept it. But even though that's painful, is because there's something that people with OCD recognize. There's a certain truth they recognize that normal people don't. And to give a slightly different example, all women know that they could be raped. But if it hasn't happened to you, you don't worry about it. It's like the car crash. I'm not really worried. If this happens to a woman, obviously treatment's going to focus on the horror of what happened. But there's something else that needs equal attention. This woman never gets to go back to that world where that won't happen. She's being asked, learn to be happy in a world where this can happen to you. And in a sense, but we can help somebody do that. But we can't say to them, it won't ever happen again. That's a hard thing for them to cope with. And I think having OCD, in a sense, is having a recognition, oh my God, anything can happen. And even if it's really unlikely, because OCD always ramps things out to a really amazingly bizarre level, there's still like, it can happen. And it's right. It's hard to kind of move to that world like, yeah, we live in a world where anything can happen. How am I going to try to make the best of it? Because it's a question once asked can't be unasked. I can't say like, yeah, I know my family's not going to die. If I, that'd be cool. I have hope.
I wanted to add to it what you were talking about, Liz, is I think unfortunately sometimes providers, and you were saying this earlier, John, is like ERP seems simplistic on paper if you're a clinician, right? Like, I'm just going to have clients do and touch things they don't like, and then they're going to learn to just get over it. I mean, besides going through ERP myself and getting trained at BTTIs and going to conferences and stuff, that you asked earlier about the conference, Liz, I learn new things all the time. It's great because John Abramowitz will say something, or you'll say something, John, or Liz, you'll say something, and I'm like, oh, I've never heard it that way. Or, inhibitory learning was this big aha moment for me, finding John's work in the 2010s when I was writing my thesis. Like, there's always more to learn. And all three of us are constantly eating, breathing, and sleeping this, whereas you might find a provider that's done one course and treats 3 people a year with OCD. So I think that's what I want people to think about is like, I get, there was a comment earlier about, providers in someone's area. we understand, right? Like we get that there's not great OCD treatment everywhere, but don't abandon the treatment because you got poor treatment, because good treatment, like you were saying, Liz, should not be like you were saying, John, at first it's going to feel worse, right? But then when you start seeing that there's an end
Progress.
to it and progress, you build that motivation and you're kicking butt, taking names. If you're not having that, and it's been 3 years with a provider, there's something missing and they just might not be the right
Yeah.
one.
And you know what? One thing that one thing you mentioned, and this drives me crazy with anybody doing any kind of treatment for OCD and otherwise. People come in and they start doing treatment the first day.
Yeah.
I'm sorry. I need to know you as a person. You're not like a number and like, oh, okay, you've got this. We're going to page 54 of the book. I have to know that person and make treatment for them, and I have to know a lot of stuff. So I don't care if it's OCD treatment or not. You know, you coming in and me giving you assignments the first day, I don't really know you well enough to give you proper treatment. But again, it's another problem I see with OC providers, but where they start doing treatment right away. It's like, I got this stuff. It's in a book. We're doing this. It's like, that's poor treatment.
So thank you. I want to just reemphasize that OCD treatment it takes a lot of trust, right? I need to trust you. I need to have a good relationship with you because we're going to be asking you to do things that you've been avoiding, that you haven't done in a long time. If a stranger's asking you to do that, of course, like it's not going to hit home correctly, right? So I think that's so important. I had another train of thought that now I've lost. Training. Thank you. Sorry, random that it popped in my head. One thing that John said, and I think is really important for us to talk about, is that we do make an assumption because of how prevalent OCD is and how debilitating it is when it's left untreated, that most clinicians should know how to treat OCD. And like John said, he would have thought at this stage in his career, he wouldn't need to do as much supervision because people would know how to do it. No, right? Like I am going to APA, which is the biggest conference for psychologists in the country. Guess how many talks they have on OCD?
Either zero
Not
or
enough.
one.
Zero.
Oh, that's impressive.
Zero. That is that y'all know how mad that makes me. So y'all know what I'm going to spend this weekend advocating for and doing, right? But it's like, how can you have an entire conference to train psychologists and there's not one OCD talk? But again, I think those of us that are in the OCD world, we just assume, well, everybody like this, it's so prevalent, it's so severe, it's so significant, and treatment works so well. Everyone must know how to do it, and they don't. People are not getting appropriately educated. People are not right. And the problem with our field is that you guys can go to Psychology Today and find a provider who says they treat OCD along with 30 other things, and this person has no real OCD training. And so just because you've been to someone who says they can treat OCD or who says they have, know how to do ERP, ask really good questions. Where did you get trained? How did you become a specialist? Where was your background? Where was your education? You really have to know that, because I do worry about how many people think they had ERP treatment and it didn't work when really they just weren't.
It was crappy ERP treatment.
It was crappy ERP treatment or not ERP at all.
Well, I mean, it's really sad that somebody reading my book will know more about OCD treatment than almost all therapists. And it's not because my book is so great. It's because the therapists are so crappy.
And the education is not specific.
Right. They don't. Yeah. Most graduate schools don't really teach OCD treatment. No. There are a few. If I go to North Carolina where John Abramowitz is, sure, I'm going to get some training, but most of them actually don't.
Yeah, all I was going to say is thank you for the advocacy, Liz, because it's sad, right? Like that's, for a major conference to have zero on OCD, it's a reminder to us, the three of us, right? But our community watching and clinicians watching, we cannot assume that everybody knows OCD treatment. There's a lot of work to do. And yeah, just sad.
So anyway, we're here, we're doing the work. Thank y'all for today. I love the conversation and just continued discussion about what ERP really is, and that reminder that it should get you freedom. And if it's not, I want you to figure out, are you doing ERP correctly? Are you receiving ERP from someone who's specialized? And is this OCD? I do think that's an important thing to talk about, is many times patients with OCD do have differentials, and ERP will work really well for their OCD. And then they've got some remaining stuff that maybe isn't OCD, but they're treating it with ERP saying, I'm not getting better. And it's like, well, yeah, because your OCD got better, but like now other stuff is showing up that you need to work on, that the intervention might be a little bit different. So be thoughtful if it's not working. Instead of saying ERP doesn't work for me, I want you to say, why isn't ERP working for me?
Ooh, I like that. I'll take the next final thought because we want to give you the final thought, John. I had Leslie Arturi, who is an OCD advocate and a therapist on, and she has a tattoo that says acceptance of uncertainty or tolerance of uncertainty. Sorry, Leslie, I butchered your tattoo. But I remember asking her what it meant to her. And she's like, as somebody with OCD, learning to just accept that I will not at all times have certainty and I can move forward in life is great as well. What I want to say to the OCD community as large, if there are people out there trying to knock down or put down the idea of tolerating and accepting uncertainty, be wary. I think it's such a useful tool for many of us in this community. And if a clinician may or may not like to utilize that, that's their choice. But to go above and beyond and try to stomp it out of our community when it helps so many people, I want people to be a little bit cautious. So that's my final thought. How about yours, John?
Well, I have two thoughts. One is, I think, and anybody with OCD, if they think about it, what am I trying to do with my rituals? I'm trying to be 100% certain. Research has shown us the only people who are 100% certain are stupid. And I don't know how to make anyone stupid enough to, become certain. And I avoid Leslie's problem because my tattoos, they don't have any writing on them, so nobody can misread them. So but it's okay. She's comfortable with that.
Do you have tattoos, Liz? Me either.
Oh, wait. I know anything's possible, but I would have bet a lot of money on no tattoos for Liz.
Yeah.
I would have bet you were a possibility. You have like a hidden tattoo. Liz, I would have been like, that happens less often than the airplane hitting the helicopter over the schoolyard during recess.
Exactly. For people who know me.
Yeah, I don't have any tattoos either, but
yeah,
you never know. Liz has 48 kids. She might just say after one day and just have a tattoo.
I do.
All of their names.
Yeah, I think John probably just knows the exposure that would have been to for me for like decades of my life.
Oh, a new exposure.
I know, right? I did see a question from somebody, just to answer it really quick, about treatment and res treatment. Feel free to reach out to me. I'm happy to answer any questions about, you were saying that people want you to commit to 2 to 12 months residential treatment, things like that. That is not what the expectation should be. So feel free to reach out to any of us. We're always happy to answer questions. You can reach me at info@houstonocd.org. And I know a lot of us, you can get in touch with us through the foundation or our own practices. So yeah, don't settle for that. I definitely hate the fact that one of the things you're saying is that people are saying if you don't get res, there's no one's willing to give you a chance in outpatient. So let's talk about it. Thanks, you guys.
Thank you all. It's a pleasure.
I'm glad you got to that question. I forgot it. Take care, everyone. Bye.